Hello students, myself Dr. Pavithran, Assistant Professor from the Department of Oral and Maxillofacial Surgery from Vinayaka Mission Shankaracharya Dental College. I will be delivering the lecture today on temporomandibular joint ankylosis. This lecture is concise and tailored for the understanding of this particular topic at an undergraduate level. So let's move on to the content. So the contents of this lecture includes anatomy of the temporomandibular joint, etiology of ankylosis, pathophysiology, classification, clinical features, investigations and management. So before jumping on to the topic what is ankylosis, let us brief what we already know, the basic anatomy of the temporomandibular joint. So as the name suggests, this joint is formed between the two bones, the temporal bone and the mandible. So for any joint you need two articulating part. The articulating part of the temporal bone is the glenoid fossa of the squamous part of the temporal bone, and from the mandible it is the head of condyle of the mandible. So in this picture you can see that this particular portion marked in red is the glenoid fossa of the temporal bone, and the one which is marked in circle is the head of condyle of the mandible. So as we all know, this temporomandibular joint has numerous names based on its function, based on its anatomy. So it's also called as diarthroidal joint, gangliomo-arthroidal joint, synovial joint, and it allows mainly two types of movements. One is the rotational movement and the translatory movement. Only because of these two movements we are able to open and close the mouth. So as I briefed before, the articulation of this joint is formed from the glenoid fossa of the temporal bone and head of condyle of the mandible. So moving on to the particular components of this joint, the bony components are the glenoid fossa and the condyle. In between these two bony components you have the interarticular disc, and the entire joint is surrounded by a fibrous capsule. Apart from that you have certain attachments of ligaments such as the sphenomandibular ligament, the stylomandibular ligament and the lateral ligament. Moving on to the topic for today's lecture, what do you mean by the term ankylosis? Ankylosis, the word in Greek, it means stiff joint. So by definition, bony or fibrous adhesion of the anatomic components of the temporomandibular joint, as a result of which you have limitation of mouth opening, which results in difficulty in mastication, speech and oral hygiene. So from this definition we understand that the bony components such as the condyle and the glenoid fossa, which is interseparated by the articular disc and allows the movement, is stopped. There is adhesions between these two articulating surfaces which leads to joint adhesions and thereby resulting in ankylosis. As a result, when these two bony components are fused together, there will be limited mouth opening or nil mouth opening, which results in difficulty in speech, mastication and maintaining the oral hygiene. Moving on to the etiological factors which contributes to temporomandibular joint ankylosis. So the first and the foremost etiology is trauma, which accounts for 31 to 98% of ankylosis. So trauma can occur from congenital, forceps delivery, condylar fractures in pediatrics or glenoid fossa fractures. So the most common etiology is during the time of delivery. When the baby is not able to be delivered properly, the doctors usually use a forceps which are usually applied in the preauricular area where the developing soft condyle is present. So when that condyle gets injured, it predisposes to ankylosis. Later in adults or in pediatrics, when the condylar fracture happens in such a manner that the condyle shatters into pieces and the intracapsular area is exposed outside, then it predisposes again to temporomandibular joint ankylosis, and finally very rarely glenoid fossa fractures. The next etiology which accounts for 10 to 49% of the cases are systemic infections such as ear infections like otitis media, mastoiditis, parotitis and hematogenous spread from diseases such as tuberculosis, gonorrhea and scarlet fever. And the least contributing etiology is by systemic disease, which contributes for about 10%, which includes ankylosing spondylitis, rheumatoid arthritis and psoriasis. So moving on to the pathophysiology or the pathogenesis, how this temporomandibular joint sequelae happens. So the most accepted and widespread accepted theory is that you have a trauma to the condyle of the mandible. whether it can be an intracapsular or extracapsular trauma. So as I told, this joint is surrounded by a fibrous capsule. So whether the injury is outside the capsule or within the capsule, the head of the condyle suffers a trauma. Because of this, there will be disruption of the capsular ligament and the periosteum covering the head of the condyle. So because as a result of which, the blood which is inside the marrow of the condyle extravasates, that means it comes outside into the joint space. So usually the blood is not present in the joint space. The joint is filled with a fluid called synovial fluid. Later, due to injury, this area is surrounded by blood, which results in a condition called as hemarthrosis, that means blood in the joint. So these exposed fractured bony fragments, that is the intramembranous bones, are all exposed outside to this environment. These bones have high osteogenic potential. Later, the blood which is extravasated into the joint space organizes to form a clot called as hematoma, which is a routine process when there is a bleeding. The next step is clot. So within the joint, after the bleeding happens, you have clot formation, and in surrounding this clot, the bony fragments have high osteogenic potential. Because of this, there will be calcification and obliteration of the joint cavity. Later, this calcification results in ossification, as a result of which there will be, because of trauma, the patient will not open and close the mouth, and the joint is filled with solid structure called as clot. So because of all these reasons, there will be immobility of the joint. So all these features over a prolonged period of time favors to initial fibrous adhesions or fibrous bands. Later, when it is not relieved, so when due to the stem pain, the inability to open mouth, fibrous adhesions, limited mouth opening, the joint is in a favorable condition that the clot first initially gets organized into fibrous band, then later the ossification from the highly osteogenic cells, the bone starts forming and it's ossify, as a result of which you have a bone that is bridged. You have a bridge of bone which is connecting the condyle and the glenoid fossa. The entire joint cavity is replaced by a stiff bone, resulting in a condition called as ankylosis. So this is the exact pathogenesis how ankylosis happens after a trauma. So moving on to the classification of temporomandibular joint ankylosis, in 1938, the first author Kazanjian, he classified ankylosis into two types, whether it is true ankylosis or false ankylosis. True ankylosis is within the capsule, that is intra-joint space, that is intra-articular. And when this happens outside the capsule, we call it as extra-articular or false ankylosis. The joint per se is not replaced by the bone, but due to injury outside the capsule, you have a bridge of bone, with the bone which is bridged between the neck of the condyle and the glenoid fossa, but the joint is safer. The next, in 1964, Topazian, he classified into stage 1, stage 2, stage 3 based upon the area of ankylosis. So ankylotic bone which is limited to the condylar process is called as stage 1. When it extends to the sigmoid notch, it is stage 2, and when it extends to the coronoid process of the mandible, which is stage 3. Later, in 1986, based on several factors, Rowe has classified the ankylosis into the following classification. First, based on the location, as Kazanjian, he has classified into extra-articular and intra-articular. Based on the type of fusion, that is, as I told, there will be bridge of some tissue this is formed between the condyle and the glenoid fossa. So based on the type of tissue, whether it is a fibrous union or fibro-osseous ankylosis or bony ankylosis. And based on the extent of fusion, whether it is complete or partial ankylosis. And finally, based upon the number of joints, whether only right side condyle is involved or the left side condyle is involved, it is either unilateral or bilateral ankylosis. So finally, in the year 1986, Shani has classified ankylosis into 4 types, type 1 to 4, based on the radiological features, which is very useful for surgical management and widely accepted in the recent days. So type 1 is minimal bone fusion but extensive fibrous adhesions. You will only have numerous, 90% of the time it is only fibrous adhesions and only less number of bony fusion around the joint. So in the first picture you can see that you have space between the condyle and the glenoid fossa. So everybody can see this radiographic image of a CT. So between this glenoid fossa and the condyle you have sufficient space. But you have here and there fibrous adhesions, here and there you have fibrous adhesions. So there will be some amount of movement, the joint is not entirely fused. Whereas in type 2, only on the periphery, that is on the margins, you will start having bony fusions, whereas the center part there is no fusion at all. That is called as type 2. Type 3, you have a bridge of bone between the mandibular condyle and the glenoid fossa, and in type 4, you cannot demarcate which is condyle and which is the glenoid fossa. Entirely the joint is replaced by bone. So this is very useful in treatment planning as well, and you will know the amount of bony fusion which has happened. So again a quick recap of this particular classification alone, you have type 1 to type 4. Type 1 you will have only majority of fibrous adhesions with less amount of bony fusion. In type 2 you have bony fusions which is happening around the periphery of the joint, and in type 3 you have bony fusions in the middle of the joint, whereas in type 4 the entire joint is replaced by bone. So moving on to the clinical features. The clinical features depends on the age at which the ankylosis happens. So if it is early stage, that is in the pediatrics which are less than 15 years of age, you have severe deformity of the face because the condyle is the growth potential for the lower face which is a mandible. So once in the early stage itself when this bone fuses, the mandible cannot grow, which results in severe facial deformity and loss of function, in sense that the patient cannot open the mouth, the patient cannot eat, patient cannot maintain the oral hygiene, that is the loss of function. If the ankylosis happens at a later stage, that is after 15 years of age, the growth is not hampered, only mild facial deformity is noted. As a result of ankylosis, the loss of function is inevitable. You will have loss of all the listed functions. So we will see first the clinical features of an unilateral ankylosis. That means that only one side of the condyle or the joint is replaced by a bony mass and resulted in a temporomandibular joint ankylosis. So for example, we will take it as one side, right side or left side. So as a result, there will be gross facial asymmetry because the balance in growth is not happening between the right and the left side, because one side is fused, one side is normally growing. So obviously you will have a gross facial asymmetry, and the mandible on the unaffected side, that is a normal growing side, the mandible tends to grow, whereas on the affected side, because the joint is fused, there will not be any growth. So because of normal growth on the affected side, the mandible tends to be pushed towards the opposite side or the unaffected side. So you will have deviation of the mandible and chin towards the affected side. So for example, in this particular picture, the patient is having ankylosis on the right side, whereas the left side you have normal growth, the mandible tends to grow normally, as a result of which the chin is pushed towards the right side, that is the ankylosed side. And you have receded chin, that means that on the affected side the mandible is not growing, you have a retrognathic or a hypoplastic mandible and a receded chin. And on the affected side the face appears full rounded, whereas on the unaffected side the face appears flat and elongated because of normal growth. And you have a deep antigonial notch on the affected side. I will be showing you in the subsequent radiographs what an antigonial notch is. Gonion is nothing but the angle of the mandible, and just in front of that area where the masseter muscle gets inserted, you have a deep concavity. The concavity is because of pull by the muscles which are attached to that area. One is the masseter, the other is the digastric muscle and the mylohyoid muscle. All these three muscles, because of constant pull during the attempt by the patient to open the mouth, the bone gets concaved in that region. I will be showing you what an antigonial notch in the subsequent orthopantomogram. And on the affected side, there will be absent condylar movements. You cannot palpate condyle in that area. There will be limited mouth opening present in a unilateral ankylosis because on the opposite side you have a normal growing condyle, and that contributes to limited mouth opening. And you have a unilateral posterior cross bite because of the affected side, and the patient obviously has a class 2 angles malocclusion. That means that there is a normal maxilla with a retrognathic mandible. Moving on to the clinical features of bilateral ankylosis. So in this picture on a lateral view, you can see that the patient's mandible is nearly absent. You cannot make over where the mandible is. So here there is no gross facial asymmetry in sense that the mandible is symmetrical, because on the both the sides the growth is arrested. So mandible is not obviously deformed. Mandible is symmetrical, but it is micrognathic, very small, or retrognathic, that is position posterior to the maxilla, which results in a characteristic feature called as anti-gum appearance. The cartoon character called anti-gum results the same appearance. So also patient have a typical bird face deformity. So there will be reduced neck. So this is the neck and this is the chin. So the angle, normal angle will be reduced because the chin is more posteriorly placed, or it is retrognathic or micrognathic. Patient has a true angles class 2 malocclusion, skeletal level. The malocclusion which we are talking is about skeletal malocclusion. The mandible is retrognathic or micrognathic, whereas the maxilla is normal. So you have a class 2 malocclusion and you have a deep antigonial notch which is present bilaterally. In an unilateral, it is on the affected side alone, whereas in the bilateral, it is on the both the sides. And you will not be able to palpate the condyle on the both the joints. There will be absent condylar movements on bilaterally. Since the joint is fused on the right side as well as on the left side, no joint is going to contribute for the oral opening. So the mouth opening will be nearly nil, 0 mm or 5 millimeters, that's all, less than 5 millimeters. Because of fusion, the posterior tooth gets contact at first, as a result of which you have an anterior open bite, severe malocclusion. Patient cannot open the mouth, patient cannot brush properly, patient cannot eat properly, as a result of which you will have poor oral hygiene, which results in multiple carious tooth and periodontal problems. Moving on to the investigations. The first and foremost investigation is an orthopantomogram. So this is an orthopantomogram which shows the ankylosis happening in the right and the left joint. So here you can see this is the glenoid fossa and the head of the mandible. In a normal orthopantomogram, one can see like this glenoid fossa with the condyle and interarticular space in an orthopantomogram. Here we cannot demarcate that space. The condyle is almost fused to the glenoid fossa on both the sides, and this side I cannot make out the condyle only. See how the malocclusion is happening. And as I told, in an orthopantomogram I will be showing what an antigonial notch is. So this is the gonion. This part of the angle of the mandible is called gonion, and here anterior to it you can have a deep concavity. So this is where you have the masseter muscle getting attached on the external surface, and on the medial surface you have the attachment of the posterior belly of digastrix and the mylohyoid muscle. So when the patient opens, these muscles contracts, resulting in the deep antialgonial notch, and here also you can make out an antigonial notch. In a normal patient, the angle of the mandible is like this and it continues as the body of the mandible without any concavity. So this feature is called as an antigonial notch. So the orthopantomogram gives us a rough idea about the ankylosis, and earlier PA cephalograms were used, and in this the chin deviation. So here the chin is deviated, in the midline the chin is deviated towards the right side. So you have points like the crista galli, you have ANS, anterior nasal spine, the crista galli, and the menton. Menton is a point on the chin. So all this will fall under a straight line in a normal patient. So whereas here in the patient's menton is deviated towards this area. So this is just an analysis earlier used, which is a PA cephalogram, and you can use a facial asymmetry analysis called as the Grumman's analysis. And lateral cephalograms very useful, because as I told, in these patients when ankylosis happens, the mandible is not growing, as a result of which what happens is this, the posterior pharyngeal airway gets reduced. So these patients suffer the breathing problem. They will have something called as obstructive sleep apnea. So quantify earlier lateral cephalograms were useful. But with the advent of computed tomography, the gold standard is to take a CT scan. So CT scan will give us an idea on the three-dimensional anatomy of the bony ankylosis which is happening. You have three sections in a CT called as the axial section, you have something called as the coronal section, and you have a sagittal section. So these three sections helps us to quantify and visualize the extent of ankylosis in the superior-inferior direction, that is up to down, mediolateral direction, and also in the antero-posterior direction. That is the three-dimensional view Also, you can, based on the image, you will come to know the size of the ankylotic mass, the amount of ankylotic mass that has to be resected in the surgery, the position of the lingula, the amount of airway, that is the posterior pharyngeal airway which I was talking in the lateral cephalogram, the relationship of the ankylotic mass to the middle cranial fossa. So you have a wide range of understanding about the amount of ankylosis and the amount of treatment that has to be delivered, the nearby important vascular structures, because there is something called as a maxillary artery which lies in close proximity to the neck of the condyle of the mandible. This maxillary artery can be entrapped in the process of ankylosis, or it can lie in close proximity to the ankylotic mass. So when you resect, we should not injure it. So all these features can be identified in the facial CT, which gives you a three-dimensional view. The below picture shows this particular picture is a three-dimensional reconstructed view from the three views, axial, coronal and sagittal. So this is helpful in explaining the patient. So this here you cannot see the head of the mandible. So this particular area is the ankylosed part, whereas here on the right side you see something called as the coronal view of the mandible. So in this you have the head of the mandible, the glenoid fossa is there, the head of the mandible is there. Here you will have limited space, so this is the ankylosed area. So before jumping on to the treatment, so we will see what if we do not treat this ankylosis at all. So sequelae of an untreated ankylosis are the normal facial growth and development is affected very severely. As a result, I told the growth is not happening, the mandible is not growing properly. The face appearance, aesthetic wise, it is drastically bad. The second concern is about function. Patient cannot open mouth, patient cannot eat, patient cannot talk properly, patient cannot brush properly, resulting in multiple carious tooth, multiple poor oral hygiene, malodor and periodontal problems, that is speech and nutrition impairment will be there. Patient will be nutritionally affected as he cannot open and eat solid foods. And you will also have respiratory distress, which I told in a bilateral involvement, bilateral temporomandibular joint ankylosis. As a result of constriction or reduced posterior pharyngeal airway, patient will have respiratory distress. Patient, when they lie supine, flat, the airway, the mandible goes back and the airway is completely obstructed. So patient will gasp for breathing. So which is, that condition is called as obstructive sleep apnea. So the features contributing are the micrognathic mandible, and the tongue, which is normally grown, will obstruct the, will fall back and obstruct the posterior pharyngeal airway. As I told, this results in a syndrome called as obstructive apnea syndrome. So it is a triad of feature. You have temporomandibular joint ankylosis, you have severe retrognathia or micrognathia, and you have associated obstructive sleep apnea. When these three conditions are present, we call it as obstructive sleep apnea syndrome, and it is an emergency. So nowadays it has to be treated immediately soon after birth if the patient is having this particular syndrome. And as I told, the last features are malocclusion, poor oral hygiene, multiple carious tooth and periodontal problems. As a result of all this, we will have to obviously treat this condition. Moving on to management, there is no medical management for this condition at all. The treatment is purely surgical. So the objectives of treatment are to restore pre-operative or we cannot call it as a pre-operative, because usually this the condition, if it is as congenital or soon after birth, there is nothing called pre-operative. So you have to restore normal mouth opening, adequate mouth opening which is needed for patient's function. Restore joint function, that is opening and closing the joint, closing the mouth. For that, the joint has to undergo rotational and translatory movements, and the joint, the condyle has to grow properly so that the subsequent growth of the patient is not affected. The growth happens up to 18 years in a male and 16 years in a female. That should not be hampered, and the facial appearance or the profile has to be corrected, and the upper airway obstruction, that is the pharyngeal airway, should be normal. When the mandible grows anteriorly normally, the posterior pharyngeal airway gets corrected. So the protocol for treating ankylosis, it was given by Caban in the year 1990. So these are all the steps mandatorily it has to be done to relieve or to treat this condition. So the first point is aggressive resection of ankylotic mass. That means that the ankylotic mass formed between the condyle and the glenoid fossa, minimum 1 centimeter has to be removed. You cannot take a strip or you cannot take a millimeters of bone and say that the joint is relieved. So because if you relieve less than 1 centimeter, what happens is that the bony fragments are in close proximity. There are chances, 100% there are chances that the fusion again happens. So hence Caban coined it by the terminology called as aggressive resection of the ankylotic mass, which is the first step. Second, ipsilateral coronoidectomy. So as a result, what happens in a ankylosis patient, many of the times when we encounter this ankylotic radiographs, the temporalis is in a constant pull. The temporalis is attached to the coronoid process. The head of the condyle is fused to the joint. The joint is not be moving, but the temporalis doesn't know this and it constantly pulls, as a result of which the coronoid process gets elongated in such a way that it goes medial to the zygomatic arch. So there can be fusion. So hence coronoidectomy on the affected site is mandatory. And if the mouth opening is less than again 35 millimeter, coronoidectomy of the opposite side is also to be done. And once the resection is done, you have created sufficient space. That means that, so here you have the glenoid fossa, here you have ankylotic mass, you have removed this box which I am forming is the aggressive resection. You have removed this. So the in between this gap has to be interposition. You have to keep a barrier material in between that so that the joint doesn't fuse back again. Re-ankylosis does not happen. So that is the fourth point, that is lining of the joint by a barrier material. Usually the nearby autogenous barrier material which is available is the temporalis fascia or some other cartilage. In the subsequent slide, I will also be talking about interpositional arthroplasty. And if the ankylosis is happening in an younger child, to accommodate for the growth, the joint, the condyle which has the joint potential, we have removed it off. So this has to be replaced by a suitable material which will contribute for the joint. So that is reconstruction of the ramus with something called as costochondral graft. So you take a costochondral graft from the ribs of the patient and you attach it to this area. So this shaded area is the resected area and here you attach costochondral graft. So costochondral graft has the inherent potential has the inherent growth potential. So that area keeps growing. The normal growth of the patient is expected. But studies have shown that costochondral graft does not give predictable growth. And the graft has to be rigidly fixed by means of plate. It cannot be left temporarily or semi-rigidly. It cannot be kept. You have to put plates and screws to the graft. And once all this is done, the aim doing all this procedure is that patient has to open the mouth. So within 10 to 15 days after the surgery, patient has to undergo active and aggressive physiotherapy, that is opening and closing the mouth beyond the pain and difficulty. So if the patient is not doing that and he is keeping the joint again in an immobilized position, there are higher chances of re-ankylosis. So quickly recapping the Caban's protocol given in 1990, you have to go for aggressive resection of the ankylotic mass, ipsilateral coronoidectomy, contralateral coronoidectomy if mouth opening is not achieved. Later, interpositioning the resected area, in between the resected area, you have to keep a barrier material like temporalis fascia or cartilage. And to accommodate for the growth potential, in 1990, Caban advocated reconstruction of the condyle, we would say, by costochondral graft and rigidly fixating it to the ramus by means of plates and screws so that the growth is happening there, and followed by aggressive physiotherapy. So later, as a result, in the previous point I told, the costochondral graft does not offer a predictable growth. Caban has modified in the year 2009 his protocol. The initial steps of the protocol remains the same: aggressive resection of the bony ankylotic mass or the fibrous ankylotic mass, whatever it is. Coronoidectomy on the affected side, that is the ipsilateral side. Coronoidectomy on the opposite side if the first and the second step do not contribute to the adequate mouth opening, which is 35 millimeters. And lining of the joint by temporalis fascia or the native disc. So the first 4 points remain the same. From the fifth point, instead of reconstructing with costochondral graft, you can have another option called as distraction osteogenesis. You can have CCG, that is costochondral graft, if it is an young child. If it is beyond 10 years or in an adult, you can use something called as distraction osteogenesis. So we put a device called as distractor and we induce or do the elongate or do the normal growth of the mandible manually by a device. Surgically we do that. So that is called as distraction osteogenesis. That is the added point. And If early mobilization or aggressive physiotherapy was the next step, so if destruction osteogenesis is used, you can use early mobilization, and if costochondral graft is used and it is rigidly fixed, after 10 days you can start. Less than 10 days the graft tends to fracture, and if it is only distraction and not graft, you can start immediate. At the physiotherapy or the mobilization of the joint can be started from the very next day itself. So the added points in 2009 are CCG can be replaced or alternated with distraction osteogenesis. If distraction osteogenesis has been the treatment, then you can do the physiotherapy from the very next day. If you are going with costochondral graft, wait for 10 days and you can start the mouth opening exercise. Physiotherapy in sense it is mouth opening and closing exercises. So moving on to the surgical techniques. So for the purpose of understanding, the surgical techniques are kept at the basic level for an undergraduate level. So the four different types of treatment are the condylectomy, gap arthroplasty, interpositional arthroplasty and temporomandibular joint reconstruction. So first is the condylectomy. Condylectomy is the removal of condyle. Here what happens is that by the term condylectomy we can understand that the condyle is still present. It could be type 1 Shani's classification where only fibrous adhesions are there and the condylar morphology is not changed. It is not replaced by the ankylotic bony mass. So the condyle is removed and fibrous adhesions are removed. So the indications goes in for a fibrous ankylosis where the joint space is obliterated only by the fibrous band and there is not deformity of the condylar head. You cannot do this procedure in a type 2, 3 and 4 Shani's ankylosis. So the steps are, you have a pre-auricular incision and the tissues are dissected and the condyle is visualized. Surgical exposure is done. Horizontal osteotomy is done. That means osteotomy is cutting of the bone. Horizontal is the horizontal fashion. So here this is the condyle. The wide portion which you can see is the condyle, and horizontal osteotomy at the neck of the condyle. So here at this level you cut the condyle and remove this condyle out, and here the fibrous adhesions that has to be removed off. Care should be taken to preserve the vital structure. So on the medial side, so this condyle we are visualizing from the lateral side. On the medial side of condyle you will be able to see the artery which I was talking is the maxillary artery. So the maxillary artery will be present on the medial surface. So you have to put some retractors or special condylar retractors and preserve the vital structures before resecting this condylar head. That is about condylectomy. The second is about gap arthroplasty. Gap arthroplasty goes for type 2, 3, 4 type of Shani's classification where the condyle you have bridge of bone in the periphery or in the center, or the entire joint is replaced by the ankylotic mass. So you have this is the glenoid fossa, you have the mandible. So in the type 2, as I told, the periphery you have the bony mass, whereas in type 3 you have the bony mass in the center, and type 4 the entire joint is replaced by the bone. So you have to go for resecting this. So you create a bony wedge between these two. That is the aim of gap arthroplasty. As previously I mentioned, you have to resect at least 1 to 1.5 centimeter of this. So this dimension 1 to 1.5 centimeter, you have to remove the bony mass to prevent re-ankylosis. The steps remains the same. Go through preauricular or an incision called as Alkiath-Bramley's incision. And Alkiath-Bramley's incision is typically with the preauricular area, you also have an extension into the temporal region. So once this flap is reflected, I will be showing in the subsequent slide what an Alkiath-Bramley's incision is. You can harvest temporalis fascia to interpose there. So it is very difficult to remove the entire ankylotic mass in single piece, and in scenarios like in the preoperative radiographs, if you have noted that the maxillary artery is entrapped within the ankylotic mass, then you will have to go for cutting the ankylotic mass into pieces. No, do not take it from in toto. Okay. So first what you do is, you have the fossa, you have the condyle, you have the bony bridge. The superior cut is given. The superior cut is given, we cannot demarcate with which is the glenoid fossa itself. So below the articular eminence you give the cut. So this part of the ankylotic mass, let it be there. So beyond this, if you go and cut, you have this is the middle cranial fossa. This area is the middle cranial fossa. Middle cranial fossa. So beyond that, if you go and cut, you will go into the brain matter. So you will leave this parallel to the articular eminence, you start your first cut. So the shaded area is your first cut. So from there you take 1 centimeter down and you give your second cut. So the cut is given by the rotary instruments burr. Later you can use chisels and osteotomes. So you can have bone removal, the instruments are large round burr. You can use chisels and osteotomes. So it is very important to create equal amount of gap. That means, so you are going to operate from the lateral surface. So you cut here, you cut here. After that, this cut has to go parallelly till the medial surface of the condyle. Otherwise, when you see on the lateral side, so this is the lateral view. So here this is the lateral and this is the medial. So your cut should go parallelly here, parallelly here. That means 1 to 1.5 centimeters should be resected laterally also, medially also. Instead, the surgeon will be able to see on this side. This side it is completely invisible. It is protected by soft tissue inside. So what happens is, laterally when you go, you give your first cut like this, and when you go medially, you should give, I told you should give like this in the previous, parallel to each other. Instead, when you go like this down and when you go like this up, the 1.5 centimeter is not achieved on the medial side, resulting in again re-ankylosis. So that should be taken care. So the literatures, that is study, shows that if inadequate arthroplasties, gap arthroplasties is done, the chances of recurrence rate are 60%, and only with sole treatment of gap arthroplasty, again without putting any barrier material in between these two, again the chances of ankylosis are 60%. So after gap arthroplasty, the additional step is interpositioning that gap with a material, barrier material, that is called as interpositional arthroplasty. The main aim of interpositional arthroplasty is you put a barrier material, can be autogenous or alloplastic, between the two cut bony ends to prevent recurrence. To the fusion should not happen again, and to the other option is, if you are going for a bony reconstruction, you can achieve normal vertical ramus height as well. So this is the various barrier materials. The autogenous ones are preferred. The most commonly used are the temporalis muscle or temporalis fascia. You can use costochondral graft, which I told in a pediatrics, you can use costochondral graft. So literatures suggest the use of metatarsal sternoclavicular joint or auricular joint. The metatarsal, sternoclavicular and auricular cartilages which are taken from these areas can also be used. Fascia lata, the dermal graft from the abdominal fat or the buccal fat pad, can also be used as an interpositional barrier material. The heterogeneous ones are, that means that are taken from some other organ species. So from the pig's bladder you can take the submucosa, and bovine cartilage can also be taken, because all these are under risk. The risk of graft, these are again foreign material, you will have the immune reactions, rejections, all those are the risk involved. So this is not preferred. The next other ones are the metals like the alloplast, the tantalum foil, gold, titanium can also be used as an interpositional arthro materials, less commonly used. And non-metallic ones are the teflons, the acrylic, ceramic implants. So these are all listed in literatures as a barrier material. The most commonly used are the temporalis fascia and temporalis muscle and abdominal fat, which has shown promising results in an interpositional arthroplasty. So this is a picture which I was talking. This is the ear of the patient. This is the temporal region of the patient. Along with the preauricular incision, you give a question mark shaped or a hockey stick shaped opening in the temporal region, which is called as Alkiat-Promley's incision, usual incision which is given for a temporomandibular joint ankylosis when you are planning interpositioning. So this is underlying one, you have the temporalis muscle and fascia. So here the temporalis fascia and the muscle, a layer of the muscle is harvested. So this can be rotated inside, and here it is sutured between the cut ends. So this is called as the interpositional arthroplasty. So this picture, the nearby area, so here only nearby to this joint space, only here in this region you have the buccal fat pad. So this buccal fat can be teased out, harvested, and can be put in between the two joints. Abdominal grafts can be harvested from the abdomen and can be used as an interpositional material, which offers very good results in terms of preventing re-ankylosis. So now the first part of the surgical modality was to resect the ankylotic mass, and the second, resect the ankylotic mass in terms of condylectomy, gap arthroplasty. To prevent re-ankylosis, we proposed interpositional arthroplasty. So once this ankylotic mass is removed, the last portion, that is the portion of the bone condyle and the ramus, whichever has been lost during surgical resection, has to be replaced. That is the reconstruction of ramus condyle unit. So the ramus condyle unit in a pediatric, as I told, it can be reconstructed with something called as costochondral graft or sternoclavicular graft, or you can also use something called distraction osteogenesis, which is the widely preferred nowadays in children's, whereas in an adult you cannot aim in distraction or a costochondral graft. You have to go for something called as temporomandibular joint prosthesis. Nowadays you would have heard about the knee replacement, hip replacement, all artificial joint. So the temporomandibular joint also, you have something called as TMJ joints are commercially available, or it can be custom made for the patient and you can attach it and you give a new joint. So these are the three options available to reconstruct ramus condyle unit. So this is the costochondral graft with a plate. So you can see this is the bony part and you have plate attached. So this will be attached to the ramus of the mandible. And this is about distraction. You have distractors which are attached. So you give a bony cut, you have two plates. Later when activated, you have distractors which are attached, and these segments move opposite direction and you have bone formation happening. This is called as distraction osteogenesis. And finally the bottom image shows the temporomandibular joint prosthesis, so which is the artificial joint. You have a glenoid component which is attached to the zygomatic arch. You have the ramus component which is attached to the remaining portion of the ramus. So these act as an artificial joint. So the surgical modalities are in depth. If you go, there are multiple steps to be followed. Planning, everything is involved. As an undergraduate level, that is not necessary. You should know what surgery has to be carried out and what are the steps in that and what are the various modalities available. As far as that, if you know, that is sufficient. So once the surgery is over, now what is the post-operative care that has to be given to the patient? The first, in the immediate post-operative period, mainly you have to take care of pain control. You have to start with soft solid diet. You cannot put immediately on a hard diet, that is hard foods. Patient cannot eat. Pain control is very, very important. Only when the patient have sufficient pain control, patient will be motivated towards physiotherapy, that is mouth opening exercises. So as far as possible, immediately you will have to start with mouth opening exercises very actively, and this exercise should be performed very frequently, that is 4 to 5 times per day for several minutes. So first in the morning half an hour, again after 2 hours, again every 2 hours the patient can do it for at least 15 to 20 minutes mouth opening exercises. Obviously the patient will have pain, and if the patient is a pediatric, the patient will not cooperate at all. For that purpose only you have adequate pain control and the patient should be motivated. So this phase is very crucial, because if the joint is not mobilized, and again if it is in a state of immobilization, there are high chances that re-ankylosis or the joint can go for a stiff joint, resulting in trismus and inability of the patient to open mouth despite doing a surgical treatment. And patient should be frequently followed in the initial period. So these are the references. Thank you so much for listening. Thank you.